thank you all for coming to this session. We really appreciate that. My name is Rhonda Garad. I represent women's health in the South East, and I'm also very privileged to be a member of the Practitioner Engagement Group, which is just one of the innovative translation strategies that ANROS has implemented in their framework. I also have the very great privilege of facilitating this session today around the women's input to a trauma-informed systems model of care in health settings, or otherwise known as the WITH study. I will now introduce the, first of all, I'd like to acknowledge the traditional owners, the Wurundjeri people of the Kulin Nation, their elders past and present, and Aboriginal women here today. Kelsey Haggerty, who many of you will know, is an academic general practitioner who currently works as a professor and leads an abuse and violence in primary care research program. Her current research includes the evidence base for interventions to prevent violence against women, education and complex interventions around identification of family violence in primary care settings and responding to women and children exposed to abuse through primary care and through the use of new technologies. So Kelsey will speak for around 20-25 minutes. She will in turn introduce her colleague, Laura, and then we'll open up discussion around the topic of system change around trauma-informed care.
Hi everybody, and it's a pleasure to be here, and I also acknowledge the traditional owners of the land and the elders past and present. And I particularly want to draw on some of the wisdom from the Aboriginal women that we've seen speaking. June Oscar said last night, or yesterday evening, seems a long time ago now, that the system needs rewiring. And that really resonates with this project because it's about changing systems of model of care in health settings, and obviously I'd like to also acknowledge the ANROS funding. So today, in the 20 minutes or so we've got, I'm going to talk about the problem, the project, the team, progress to date, and some of the tables have got a flow chart on it of the different phases, obviously a state of knowledge paper, also interviews with women and digital stories that we've developed, and then some deliberative dialogue workshops. And this theme of art that's starting to come in this session is quite interesting. And then hopefully we'll have time for some implications and discussion. I'm going to show you a digital story.
I was cracking under the weight. I needed help to carry it. I made a phone call. I didn't know what would happen, but I knew what I was supposed to do. As a health professional, I told other women to do the same thing many times. Before, I thought services were a net. We all cared and we all worked together so that we could catch people when they fell. Then I found out that we're really all just passing people along, passing the problem along. I took the weight to the GP. She was sympathetic, but uncomfortable. The waiting room was busy, and I used to work with the receptionist. She recognised me. The first place was soft and kind, and there was talking, so much talking. There were posters of rainforests and clouds and butterflies and motivational quotes. There were tissues and books about feelings and it's not your fault, but I know that. I didn't just decide to pick up this weight and carry it with me everywhere. That was a circle, around and around, and eventually it was the end. There aren't enough resources. There isn't enough funding. The waiting list is growing. We could put you on it and maybe see you in 3 months. I didn't care. I couldn't keep talking while the weight kept growing. I thought I was going to carry it for the rest of my life. The second place was progressive and experimental and horrific. They told me to get to know the weight, to feel just how heavy it was, as though this would help me carry it. But I felt like the weight had doubled. It felt like it would break my back. Inside, I was screaming and running down the street. If anyone was listening, they would have heard, "Get me the fuck out of here." They said, "Okay, that will be $90 and we'll see you in a week." The third place was warm and the chair was comfy. I could have slept in there. I probably did sleep in there. And that was fine. There was time. She was practical and realistic and gave me a plan that I understood. I was no longer walking around in circles. I was going somewhere. I don't know how, but each time I left, the weight felt a little lighter. Nobody carried it for me, but she showed me how to put it down.
So I couldn't tell you the problem any better than those words that we're trying to address with this. We're working quite a lot with survivors, and I'd like to also acknowledge all the survivors in the room, particularly those who've had sexual violence and mental health issues. And I hope that the work we're doing resonates with your experiences. And, I think that it's important not to think we're helping people out there, we're here. So it's a good thing to remember. But the problem we're trying to address with this project that was illustrated so beautifully by those words is that although there's a lot of overlap with mental health and sexual violence and that the services support the same women, there's siloing of pathways to care. And we could add in domestic violence, child protection, alcohol and drug. We could make more silos. This particular one is just looking at sexual violence and mental health. And services are familiar with trauma-informed care, but there's no system model, and I will explain that in a minute. And so I've done some work with the World Health Organisation and Claudia Garcia Moreno around a health systems approach. And this project is asking how can we promote and embed a trauma-informed systems model of care responsive to consumers and practitioners into the complex system of mental health and sexual violence services. It's a multi-phase project and involving the Women's Hospital and Casa House, Northern Area Mental Health Service and a community mental health service that we haven't picked yet. And we're really trying to see how services can work more effectively so that women aren't experiencing what you just saw in the digital story. There's a huge team, and I wish I could say, like everybody else, that the collaboration's been great and easy and all those things. We're in different states. Some people are international. We've struggled in the time frame to engage everybody. We're engaged with, obviously, the people at the University of Melbourne. We're working well with Susan Rees from University of New South Wales and obviously Antonia Cordara from AFSIS in Melbourne. But then the tricky thing is there's lots of people with wisdom such as Corrine Henderson and Kathy Kesselman who have done a wealth of experience and it's been hard for us to also engage them as well as get on and do what we need to do in the project. And I just think that sometimes the collaboration means there's a delay in the project or you're doing the project and you can't collaborate quite as easily with all the players. But the lived experience panel that we're developing as part of the Melbourne Research Alliance to End Violence Against Women that Kathy Humphries spoke about, we're really serious about working with survivors and are paying attention to that. And we've also got a PhD student called Carol O'Dwyer who's just about to start as well, and she's going to work in the area of disability. So the progress to date is the wonderful literature review by Antonia Cordara, and I'm just going to give you a little snapshot of that. And I don't think Antonia's here, or we'd have her up on the stage too. We're going to talk briefly about the interviews with women in New South Wales that Susan Rees has done, many of you will know her. And then Laura Tarzia, who's my colleague in the Department of General Practice, who's a research fellow there and has a sociology and gender studies background, will talk to you about the interviews. And then we will you know, the next phase of it is the digital storing workshop, which we already have done, but there's interviews with these women, and unfortunately my slides have moved a bit, and Delaney Woodlock's name is in blue and is not showing up. She's from DVRCV, and she's interviewing women about what it was like to make that digital story. Laura and I went to the workshops with them. I made one of my own. It's quite an interesting experience. You get to pick what pictures you put on, how you put them on, what story you tell. The Australian Centre for the Moving Image facilitators just are amazing at getting people to really get the essence of their story, and it's a wonderful experience if any of you want to talk to us about that. I won't be talking more about that at the moment. So the State of Knowledge paper did try and look at the trauma-informed models guiding organisations and what evidence. And this is a bit funny because, of course, you write your project and you do a literature review and you hope this is a gap. And then, of course, we were doing a State of Knowledge paper as part of it. And imagine if we found out that actually it had been done 1 million times somewhere else and our brief literature review hadn't identified. But in fact, it basically showed there were consistent themes about the principles of trauma-informed care, but very little evaluative evidence to inform organisational system change. And the things that seemed important in the minimal amount of evaluations was this comprehensiveness or wraparound of approaches, integration of clinical and organisational levels, delivery, obviously, of trauma-informed services, and consumer survivor involvement. They were the key things that might be helpful. And the review did recommend 2 questions that are very similar to what we're answering around how can we better integrate the 2 services and how can we implement it on an organisational level. So that was reassuring that we still needed to do it. And these principles of trauma-informed care are lovely. You know, understanding that the prevalence and nature of trauma arises from interpersonal violence and impacts, ensure that at every level there's physical and emotional safety of consumer survivors, creating service cultures that empower people in recovery, autonomy, collaboration and strength-based approaches. And I think we've got a lot to learn from Aboriginal healing approaches. And recognising and being responsive to the lived social and cultural context as recovery and healing occurs, and recognising the relational nature of both trauma and healing. But as I said, there was very little evidence, and there was a tendency to focus on individual or proxy indicators to suggest changes in organisational practice in mental health settings. 4 qualitative studies identified key outcomes. Those were the ones I read out before, and certainly limited research into diverse populations. Susan Rees has been examining the mechanisms linking sexual assault and mental health issues and connecting mental health issues with sexual assault. And she's interviewed 30 participants from the sexual assault service at the Royal Prince Alfred. And she's used a timeline approach, which she really thinks is an effective tool for understanding the patterns of life. And she feels that many participants commented on the therapeutic or empowering experience as a method. And she hasn't got results yet. She's had a look at the data, and she really feels that there's going to be substantial policy and practice lessons that can be generated from these interviews, very in-depth, long interviews using timeline. So I'm going to pass back over to Laura now, who did the interviews here in Victoria with a different focus.
Thanks, Kelsey. Yes, I'm just going to talk briefly about the interviews that I did with women in Victoria. So my interviews were focusing on women's pathways to safety and care when they'd experienced both mental health issues and sexual violence. So it was really around a focus on accessing services and the things that they found positive or negative about that experience. So my interviews were a different methodology to what Susan used. Mine were very sort of narrative, open-ended interviews. I basically just started off with a single question asking them, can you tell me about your experiences accessing services, and let them go from there. And some of them talked for over 2 hours just with that single prompt, which was great. So some preliminary themes that emerge from our analysis of that data are connect me, hear me, and help heal me holistically. So I'll talk briefly about each of those themes and also some of the issues and barriers around achieving those things. So the first theme, connect me, really was focusing on women's desire to sort of feel connected within a network of services. They felt that they wanted to be made aware of and be assisted to access trauma-informed services. So one woman says, all of the services I've accessed, I've had to seek them out myself. So they sort of felt like there wasn't a lot of information out there to guide them in finding and accessing appropriate services. They wanted to be referred onto other services where appropriate. So if they went somewhere for one issue and then they also had other things going on, they wanted the service providers to be able to suggest, okay, so, you know, we know this other service, they're really good, they're trauma-informed, you could actually go there as well and address this other issue. And they also wanted services to be better integrated, which of course, you know, strongly reflects what Kelsey was saying about what's in the literature as well. They felt that there was a lack of information sharing between services. So obviously with the caveat that things had to be done with women's permission and the women wanted to feel like they had control over what information was shared, but they thought that it would be really useful if they were accessing a mental health service and had previously accessed a sexual assault service, that there would be some kind of information sharing between those services so they didn't have to repeat the same things to 2 different or 3 or more different services. So a couple of issues and barriers around feeling connected. Obviously, funding for services is a really obvious one that I'm sure we're all aware of. A lot of women, you know, noticed that there just weren't enough resources for services to be able to deal with the influx of people trying to access them. They found that there were some issues around services being inflexible. So, for instance, for this particular participant who was working, the service had said to her, well, we can help you if you turn up at 10 o'clock on a Tuesday morning, which obviously was not appropriate for her because she was busy and there was sort of no other option provided for when she could go and seek help. Some women also pointed out that there wasn't an ongoing support from services. So while they appreciated a referral, they didn't want to feel like a service had just kind of washed their hands and said, okay, we've referred you, see you later. They actually appreciated follow-up from the original service to say, how did you get on with the person that I referred you to? The second theme was hear me, which I think is pretty self-evident. Women really had a strong need to feel heard and validated by the services that they were accessing. So this participant mentions that a service provider gave her a whole list of symptoms that someone might experience if they were suffering from post-traumatic stress, and she was able to tick off every single symptom on the list and instantly felt like, okay, this person understands what I'm going through. Women wanted to be connected with the right person, so they acknowledged that sometimes they would have to kind of shop around a bit before they found the person that was the right fit for them, and that was okay, and it was important to do that. Because as the second quote there illustrates, this one woman had been seeing a psychologist for a number of years and still didn't really feel comfortable disclosing a sexual assault and trauma, and felt like maybe deep down she knew that this person wasn't the right person that she felt comfortable talking to. Women also felt it was extremely important to have a trust relationship with services because they felt like they were disclosing pretty much the worst thing that they could tell someone, and that it was really important that they could feel a sense of trust that the information they were giving was not going to be misused in any way. Again, some issues and barriers around being heard. So the sense that someone was sitting there listening but not really listening was a huge thing that women mentioned in the interviews, that made them feel really bad when they would go and talk for 2 hours and then the person might turn around and say in the next visit, oh, where were we up to again? I can't really remember. They didn't obviously like that. And leading on from that, a feeling like no one out there could actually help them. That made women feel very isolated and very unhappy, and was quite a re-traumatising sensation that wasn't actually help available out there for them. As the last quote there illustrates, I sort of gave up a little bit and thought, well, if the Centre Against Sexual Assault can't help me, who will? A lack of specific training in sexual assault for mental health services was another theme that emerged as a barrier. So women felt that some of the mental health services just didn't understand the nature of sexual abuse and pointed out that how can you really treat the problem if you don't understand what it is and, you know, the things that go along with it. And so I think the last quote there is also a really interesting suggestion. If 1 in 3 women are coming to your service because of that being sexual assault, then one in 3 of your workers in that service should be experienced in that area, because that's reality. The third theme was women's desire to feel like they were being helped to heal holistically. And a big important part of that was being treated like an individual by services. So, for instance, this one participant who had accessed a lot of services and was quite experienced engaging with the system said, the sexual assault services would just get me to yarn and yarn and yarn. And some of them, on the other hand, would expect me to unpack all the trauma, and others wouldn't even want to deal with it. There's never a balance. There was never, what do you want to work on? They never asked me. To thrive and not just survive, I think, was another really great theme that came out of this work. So a number of women pointed out that some services can get you to a point where you're getting by, but that they actually wanted more than that. That the second quote there's a huge difference between surviving and thriving. Their job is to help you survive, but it's got nothing to do with how to thrive, how to actually get your life back. And practical help was the last sub-theme there. Women sort of had different views on this. Some women really liked the opportunity to just sort of talk and unpack things, whereas others felt very strongly that the provision of practical strategies to actually move forward was a very important part of their healing process. And I think that came out nicely in the digital story as well. So this first person says, I think I expected a little bit more, let's talk about how you're feeling, and this isn't your fault, blah, 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 which I was really over. I just wanted to put it in the past. I wanted to close that door, so the really practical approach was helpful. And I'll just quickly go through those barriers for that theme, different paradigms. This was a big issue, I think. The sort of feminist framework that a lot of sexual assault services operate from sometimes clashed with particularly the more acute mental health services that tend to have a more clinical model. There was a bit of issues around those services integrating well together when they do come from those very different frameworks. And a lack of individualised care was also an issue, that services weren't always responsive to different needs of women. So I'll hand back to Kelsey. Okay.
So you're starting to get the themes coming through from the women that are very clear. I'm just going to spend a few minutes just talking about phase 3 now, which is where we're, this second year, so that's what we've done in the first year. This second year we're going to work under deliberative dialogue workshops and particularly look around this model. And the model actually works at various levels, and the purple parts are where often organisations, big hospitals, other places have enacted some policies, they've done some training. They may not have a whole lot of practitioner support around this area or designated champions. They've got some protocols, referral networks. Often coordination is internal rather than external, whereas women are often asking for external as well. There's not enough financing, there's not enough information system and sharing, so you can't monitor and evaluate. And the health infrastructure of the environment, I think some places have really worked hard on that so that you're not re-traumatised while you're sitting in a waiting room. And these are some health system models from the US and New Zealand, and they're being evaluated. And so I think we can certainly look internationally to look at these sort of integrated models at different levels. Our current next steps are we've started some discussion groups with practitioners and staff, focusing on choosing an aspect that they want to change and enact over this next 3 to 6 months that we can evaluate. They're being co-facilitated by survivors, and that's been a great experience for us to work where the survivors are co-facilitating with us. And deliberative dialogue is really where someone gets a brief, and we've been using the digital stories as part of that and other things, where they're actually wanting to weigh up alternatives, not debate them, but to actually move forward as an open-minded discussion. And they've been working quite well, and we've given them the literature and guidelines and models, the interviews with women, and I'm just going to finish on evidence of what makes practitioners change. So there's million systematic reviews on how you change health professional behaviour. One way is persuasive, and local consensus process and opinion leaders. They probably, the local opinion leaders work better than the local consensus processes. So it's getting key people as champions. And so persuasion alone won't work, probably nothing alone will work. When it's combined with action and monitoring, so audit and feedback and reminders, and particularly if the audit and feedback is the health professionals are not performing well to start out with, well, I think that that's true in this case. The person responsible is a supervisor or a colleague. It's provided more than once, and it includes clear targets. And computer reminders and clinical decision supports also can help with effect on patient outcomes. But of course, the problems with this is resourcing. And the final one is educational and informational, and we've all been to a million things that are distribution of educational materials or educational meetings. They don't work as well as educational outreach, where a colleague or a peer is actually working one-on-one with someone. And patient-mediated interventions where a patient is prompted to ask the health professional work well too. But again, we've got a lot of training and not so much educational outreach. So we're going to work closely with them and then try and document the process and evaluate it. So watch this space. I'm sure we'll be back for the next one to tell you how we've gone this year in trying to change behaviour. Our timeline is this, and what I want to finish with is to say that we're hoping to get funded an art exhibition in the foyers of the hospitals we're working with, and we're working on that. And really, these are the implications that maybe we could discuss at the table around the lack of evidence of what works. Women are not consistently being connected, and there's siloing of services. And I never want to hear a quote like this again if we manage to do something. Oh. Do you want me to go back to that slide?
Yeah, that'd be great. So thank you very much to Kelsey and Laura for a fantastic summary of their work and highlighting some of the rich data that they've evidenced through their work. What we would really like to do now is to tap into the wealth of intelligence in the room, and we would ask that you would, in your tables or close to people you're sitting with, talk amongst yourselves around the central questions of this study, which are around implementing or integrating service level change around trauma-informed care. So knowing what you do as practitioners and as people out there in the field, how to do this best, what are the leverage points, what can we influence, what can we change, what is the best way to do this. So if you wouldn't mind just spending 5 minutes talking with each other and then nominating perhaps one person at your table to talk, give us the key points from your discussion, and we would really appreciate if you would do that. All right, so we might just call you all back to the back from your rich discussions there. It looks like a lot of great discussion, which is fabulous. So we really want to know what you were talking about. So what I would ask for is just a couple of quick points. One from each table. So this is a challenge to you. So I might literally work around the room. If I can start from this table up here and get people 1 point from your table. Oh, this is a challenge to the microphone.
I
I think you're it.
Oh, thank you, yeah. I think we've come up with the conclusion that capacity is the issue. People do come into your centre and you do refer them and they do get bounced around and you don't have the follow-up because you've got more coming through the door. So I think you have to do a wraparound service and you really have to be selective and who do you choose to get that service. And then also we find the lack of trauma-informed counselling available is also an issue.
Thank you. Wonderful.
Yeah, is this working? Yeah, there's a big workforce development that needs in mental health, but also connecting the services together. You know, like I think that Casa House and mental health at the centre at the Women's have not spent a lot of time together, and so that's going to be interesting.
All right, so we might go on. Can I? Yeah.
Sure. We were talking about the, I guess, the synergy or the connection between trauma-informed work and also work by practitioners or therapists such as Dr. Alan Wade, who looks at women's resistance to violence and I suppose has a bit of a different approach, and how we can straddle those two, I guess, worlds, because what we don't want to do is pathologise victims and have them being set up as having the problem, but certainly acknowledging that trauma plays, you know, that victims do have a variety of trauma that they present with. So I guess it's about the learnings that we can get from both of those two conversations.
Yeah. And I think the principles of trauma-informed care are about strengths approach. So, you know, there's also the recovery model in Victoria, you know, which is very same, empowering. There's lots of these frameworks. We're just utilising this particular one at this point in time, but acknowledge it. Yeah.
Thank you very much. Do you want to? Yeah. I don't want to run the microphone. Yeah. Rose, it looks like you're it, I think.
I've probably did most of the speaking. The only thing I know about this is that the organisation that my position's auspiced by has a massive commitment to trauma-informed care, and I started my position in October, and I think within a week I had an email from the central office saying, here are your workshops that you will be attending in trauma-informed care. So they're rolling it out right across the organisation, top down, everyone, whether you're direct service or not, and they have a practice leader position within the organisation that's actually driving that initiative. So they're only in, I think, phase 1 at the moment, which was basically getting a level of training across the entire organisation. It's quite a large one.
And I hope you got the message that training alone is insufficient. And so, you know, people only have one or two of those elements of the system. It probably needs almost all those elements.
Yeah, I believe there's probably a massive strategy behind that. That's, at the moment, that's my experience of it. But I'm sure there's a whole range of other things that are going to be happening with it.
Yeah, sounds like a wonderful approach. Thank you.
So our table thought that it would be really helpful to have some sort of online database or platforms to connect people, to connect potential clients with service providers, and not just in a way that, looks at it in very kind of technical version, but something that communicates the personal as well. So before they approach the person, it's not just something that's located in the place that they are physically located, but someone they can potentially relate to. And the other one was that there's a problem of pathologising the mental health area.
Sorry.
My writing. There's a surprise, Kelsey. I guess I was just saying that in the work I've previously done in the domestic violence and mental health area, interviewing survivors, there was an issue about the mental health service pathologising and diagnosing, and they were very clear that they were saying that they saw this as symptoms of abuse, not of, and that a diagnosis of mental health in certain situations was not very helpful at all for them. So I guess that's a part of that, the barriers between the two systems and the different approaches, and it also probably is simplistic in terms of thinking about mental health services, which now these days do go beyond that quite significantly.
Wonderful, thank you very much. We could do with some more microphones, I think. Just no, move on. So we might just have time for a couple more, I think. Yep.
Okay. I really agree with the concerns about being referred on and referred on. I'm from the Domestic Violence Crisis Service in the ACT, and we certainly work quite hard at practicing trauma-informed care, but I am also aware that there's limitations around referral. So, for instance, we don't have a list of people that we can refer to and recommendations, just as in the legal respect and family law respect. I mean, we don't have a list of family law solicitors that we can refer on to either, because we're actually told not to make recommendations. It's very fluid, it changes all the time, it's very subjective. So we would refer on to another service who outsources, who would then refer on to who they outsource to. And it's very problematic, but I'm not too sure how we work our way around that.
Yeah, that's all I've got to say. Yep.
So we talked in our group about the role of primary care and about family doctors, GPs, and just the problem there with getting people into care to start with, and how you set up systems to enable GPs to engage with patients. So we know that women are likely to disclose to GPs that GPs are not very good at dealing with those disclosures, and we were just trying to apply that at a kind of systems level to look at how GPs could be better.
So the College of GPs has done an enormous amount of work in this area. There's just go online, look at the white book, look at the domestic line. There's an active learning module. Everybody is training GPs in Victoria at the moment. I think they're a really key resource, and in fact, women often find them. The good ones really good. So I think it's just enhancing, yeah. But there's a lot of work in this space, yeah.
All right, unfortunately we're going to have to sort of wind things up there. Apologise for not getting to everybody, but I hope you enjoyed that discussion, and Kelsey and Laura are very, very welcoming of any further discussion during lunchtime. They don't need to eat, they're fine. So I wish to thank you all very much. It's been a terrific session, and I really appreciate your inclusion. Thank you very much.